Like what Ivan was talking about is how do we use the Osiris and total wavefront aberrometry in our daily practices, and in this case, in planning and follow-up of the ICL. Now, for my understanding, who of you is familiar with the Osiris in daily practice? Oi. Oh, okay. So not many in the room. So, okay, good. No worries. Well, when planning ICL surgery, of course, we do a number of tests, and one of them is the wavefront aberrometry with the Osiris. As you can see here, the Osiris can measure myopia, hyperopia, astigmatism, but also the higher order aberrations, telling us what is the quality of the eye before surgery, actually. You can see it here. So this is the refractive error. It shows it for a 4 millimeter pupil with a vertex distance of 0 or 12.5. And as we all know, the higher the myopia, the more myopia you have to have in your glasses in respect to contact lenses. So that is actually also the same, which is, excuse me, is pointed out over here. And even when the pupil dilates, they get a little bit more myopic. Here you have the higher order aberration summary. The most important for refractive surgery are coma and spherical aberration. This is a very nice example of a myope with high astigmatism, and it helps us to understand. So it says like minus 4.2 to minus 4.9, and it gives us the axis in all measurements 3 degrees. So then we can be sure that that axis, the cylinder axis, has to be in 3 degrees. So it's important to have a look at that. When planning the surgery, of course, when you put in an ICL and it's a myope or a hyperope without astigmatism, it doesn't matter where to put the ICL. It corrects the ametropia. But of course, when you have to correct astigmatism, you want to have that ICL in the exact spot to correct the cylinder, because every 3 degrees of misalignment, you get a decrease of 10% in your astigmatism correction. So 3 degrees is not much. It's very powerful if you not put the toric ICL in the right position. So that's what it's saying here, and also it predicts also what will be the visual result afterwards. Let me give you some examples. This example here, it's a myope minus 2.2 minus 4.25 cylinder. When we look at here, we see that all higher order aberrations are within normal range. So when you put in the ICL, we know that the visual quality, when you correct the refractive error, will be good. This is after surgery. You see there's still minus a half left and a quarter of a diopter. And when we look at the higher order aberrations, again, within normal. That's what you expect with the ICL or with phakic lens implants. They do not mess up your higher order aberrations. This is not true for corneal refractive surgery. So there's always a change of higher order aberrations there. This is the same, the higher order aberration, but you can see here clearly defined the aquaport. And you can see that it is not in the center. Why it's not in the center? This is a left eye, which means the ICL is to the temporal side, and most of our pupils are more nasally in the iris, so it makes sense. So the ICL centers in the sulcus, not in respect to the pupil. This can be important to see whether the ICL is decentered a lot, so specifically when you put in an ICL which corrects presbyopia. But I will give an example later on. What about the post-op evaluation? You can have a look on what is there still a refractive error? Yes or no? Is the cylinder in the right position? Is there a cylinder which has to be corrected? Or do you need to rotate the lens? Yes or no? For example, when you have a dissatisfied patient post-op toric ICL, you can go to the Osiris and you type in here, it's a minus 10 cylinder +3, axis 101. But maybe you don't know this, but the ICL doesn't come always with that cylinder in the right axis, meaning when you put in the toric ICL in the horizontal axis, sometimes you have to rotate it to match the cylinder correction of the toric ICL with the ICE cylinder. And that's the case here. So I had to rotate the lens 5 degrees clockwise to get the right correction. So this patient was dissatisfied. Why? Because he was left with a cylinder, so plus 0.5, minus 1 at 150 degrees. When you have a decentration, also not a rotation of the ICL, the cylindrical correction diminishes, but also the axis changes. When you have a diagonal axis here for the refraction, then you get dissatisfied patients. So what do we do? So we enter the lens power, we enter the reclamation recommended, that's we did here. Then we double check the ICL rotation diagram to match here on the left-hand side below. Then, because this center hole is mostly somewhere else, so you just take it with your mouse and you drag it to the center, so to the aquaport here. And then you align the red line with the markings, with the toric ICL markings on the ICL. And then the software tells you what to do. You have to rotate this lens towards the green line to get the correction. Understood? Is this clear? So this is, you can inform the eye surgeons how to do it. It's easy, it's fast, it goes fast. And that's what I did. So this is the same eye preoperatively. Again, the cylinder left here and the visual quality with the chart which is projected on the retina, as Ivan pointed out. And this was the result. And you can see I did the same thing. And you can see it's still not perfect, but only a few degrees rotation in respect to the ideal position of the lens. He was still left with plus a quarter, minus a half cylinder at 26 degrees. So even when I rotate it even more to 2 degrees, then I could diminish the cylinder from 0.5 to 0.45. Of course, we're not going to do that because the patient will not see the difference. So this was the end result of this patient. So the Osiris guides you what to do, how much to rotate the lens, and postoperatively check whether the lens is the right position. And when the lens is not in the right position, how to improve even more, or in this case, we can rotate it another 2 degrees, but it will not help the refraction getting better. So no point in doing anything more for this eye. Here you have a nice example of, you can see here the markings on the ICL, meaning how the ICL is rotated in respect to the horizontal axis. Another example, this is a post-hyperopic, toric hyperopic ICL. As you can see here, it's +8 with a cylinder of 2.5. In the left eye, +7.5, cylinder 2.5. Patient was happy, but still I did this just to see what we improve. In the right eye, we can rotate it 3 degrees to get an improvement of 0.15 diopter in cylinder. Doesn't make any sense to do that. In the left eye, we could rotate more than, let's see, 7 degrees approximately. I think 7 degrees, if I can see here. And it's the cylinder pre-op was minus 0.9, and we could improve it to minus 0.5. But this patient was satisfied. We're not going to intervene on an eye on a patient who is satisfied with his vision. To have only 0.4 gain in cylindric refraction. So we did not do anything. Here again, this is the same patient looking at the visual quality, the point spread function. It's not ideal, but remember it was a high hyperope, +7.5 to +8 with 2.5 diopters of cylinder. They're always happy because they gain for distance and they gain for near. So they're easy to please, actually. This was an attempt to make a smile, but the surgeon couldn't take out the lenticule. You can see the roughness here in the interface. And here you can see how it looks like in the refractive error. It's, oh, sorry, yeah. That's how it looks like. So you can appreciate the quality of that eye before doing something. What will we do? Will we do corneal refractive surgery or put in an ICL? That guides us in these decisions. And what happened here? So it is a patient with decreased vision after years after ICL. When looking at the higher order aberrations, it doesn't tell you that much. But when you look at the retroillumination, the infrared image, it shows you that it is an eye with cataract. So it also proves, it is very good for your medical records, that to prove that this was a cataract. What to do here? You see this toric ICL, and you see some pigment on the ICL. What will we do? We checked. Look, the visual quality is very good. No, not a lot of higher order aberrations. So, and also we checked it was also a toric ICL, -9 cylinder 1.5. The post-op refraction was +0.5, -0.5 upon 174 degrees. When we rotate this lens, it is at a 2-degree position, ideally 174, so it's an 8 degrees of rotation clockwise, and the post-op refraction would become +0.4 -1/4. So again, only gain of 1/4 of refractive cylinder. You don't do anything, you just wait. This is another patient referred to me. He was implanted with an iris glow lens many years ago, but the surgery didn't go pretty well. The incision was located superiorly and there was an iris prolapse. The surgeon had to dissect and remove the iris. You can see here the hole, not the iris is not covering this part of the lens, and a decreased visual acuity. What can you do here? Not much, because it's. But the patient came for advice for the other eye. So what did I do? I put in an ICL in the other eye with a very good visual quality, and as you can see here on the retroillumination. Then let's go to the presbyopia correcting phakic IOLs. To my knowledge, there are two. You have the IPCL presbyopia correcting lens, and it's, as you can see here, it's diffractive, is a refractive design. It has some other holes to ensure that the aqueous flows from behind the iris to the pupil in the anterior chamber. And you can appreciate here the centration. You can look, is it well centered, yes or no? And is there an induction of higher order aberrations, yes or no? And again, the visual quality, which is pretty good in this case. The thing is, this is a bifocal one. Those patients, they complain of the intermediate vision. They see good for near, they see good for distance, but intermediate it's not a trifocal design, so it's not that good. And then we have the vision ICL, the Viva, the V6, the Viva. I did the original study, European study, and it was not so successful. Why it was not so successful? This lens works with induction of spherical aberration. You can appreciate it's very good here on that image, showing us the higher order aberrations and the refractive error. So it plays with minus and so negative and positive spherical aberration in different orders. And what the problem is, I told you the ICL fits in the sulcus, so it's not in respect to the pupil or the visual axis. And when you have, in many cases, a decentration, you end up with a lot of coma. Here, in this case, the coma is still acceptable, but in many cases, you have a lot of coma and those patients are not satisfied. And also here you can see 0.36 microns of spherical aberration. And that's how that lens works. This is the right eye of the patient. This is the visual quality. You can see it's a little bit blurry. And it takes up to 3 months for patients to get accustomed to this type of lens. This is the other eye. You can see again, here the coma is even more, 0.37 because of more decentration, and again 0.46 of spherical aberration. And that's why the patient can read without glasses. The distance vision dropped 2 lines, in this case uncorrected. So you have to bear that in mind when doing this kind of surgeries. So, and the last, what is the advantage of the Osiris? You can improve your technique. You can see what is the visual quality before surgery, what is it after surgery. You can compare, what can you improve? And it's also benchmark. It is used for benchmarking because it provides you, and it can compare, in the last case with the presbyopia correcting phakic IOLs, which is the best one, which is performing better, the presbyopia correcting IPCL or the one from STAR. So in conclusion, we can say that the Osiris gives us a total aberrometry and gives us information to do a pre-op assessment of surgery, to plan the surgery, and also to evaluate postoperatively how did you do during the surgery. What can you improve? Can you rotate the toric ICL? Will it give you an improvement in refraction? Yes or no? So thank you very much for your attention.